no worries about anything in the chat box that you send to anyone. It's all confidential and anonymous, so it won't be shared. And so welcome, Assalamu alaikum everyone. We're really, really blessed that you decided to spend your Sunday with us. My name is Samira and I'm one of 3 speakers for today. And I would like to ask that everybody please stay on mute while we're presenting, because we don't want to eliminate distractions and background noise. And this is a pelvic health webinar for Muslims. So we'll be going through a lot of information tonight. And so to get started, I wanted Dr. Samhouri and Dr. Ahmed to introduce themselves, and then we'll move on with the content from there.
So my name is Dr. Zeba Ahmed. I am New York trained physiatrist. I went to medical school here in New York. I did my residency in New York City at NYU, and I've been in private practice ever since I graduated. And now I am specifically treating pelvic pain in both men and women. And the reason I started my social media and these webinars and it was mostly to increase the awareness of pelvic health in Muslim people, both men and women, and to kind of take down some taboos and myths that people have regarding pelvic pain, intercourse, menstruation. And so that's my passion.
I'm Dr. Summer Samhouri. I'm trained in New York City. All of my education was in New York City. Moved to Tampa, Florida, where I'm treating currently now for the past 3 years, primarily at USF now. And my passion for pelvic physical therapy came from my own personal experiences and wanting to give women like myself a voice in what happens to them when they're pregnant, during childbirth, and all of these things that we really don't know much about. And so for the past 11 years, I've been primarily focusing on pelvic health in men, women, and children.
Awesome. We're really blessed to have you both share your expertise. My name is Samira. I run a platform called Sexual Health for Muslims. I've been in a really interesting space of sexual health education with Muslims in the US and Canada, and recently left nonprofit work because I really wanted to focus on sexual health education. And so I've endured my own challenges with pelvic health, and this topic is very near and dear to me, and feel really blessed that we have 2 incredible Muslim professionals here who'll be sharing a lot of helpful information, hopefully, with you all. So a few things to get started. This is going to probably be a larger platform as people join. So we wanted to just bring some agreements into the space, given the sensitivity and also the heaviness of this topic. So we wanted you all to just remember that there might be some discomfort with feelings or thoughts that may come up if you're enduring pelvic pain yourself, or this is a topic you haven't learned about, and that's normal. As Muslims, we haven't had access to these spaces before. So really grant yourself some compassion, and also compassion towards others you may interact with on the Zoom webinar. We encourage you to go as deep as you'd like with information and not drown. So we are recording this, you'll have access to it, you can go back to it and listen. So don't feel like you have to absorb everything this evening. We'd like you to keep an open mind. A lot of what we talk about might be new, and so just see how it lands with you and explore it as you think further and reflect. We also want you to think about simultaneity. So oftentimes we may think that if we're dealing with pelvic pain, that we're a broken person, that we're not sexual, and we know that that's not true because God gave us the ability to be sexual, and that's sacred, and nothing can take that away, including pain or any other issues that you're dealing with. And also stay the whole time means if you are able to stay till the end, awesome. But also, as both Dr. Samhouri and Dr. Ahmed will be speaking about, pelvic pain can be a long journey and a difficult one. So just being aware that this is maybe something that you're dealing with day to day and things change. So inshallah that these help you as you go through the content. So this evening we'll be going through 3 objectives. The first is going to be really brief and demystify pelvic and sexual health with regards to Islam and being Muslim. Next, there'll be a lot of information about the pelvic floor, anatomical, muscular, nerves, and function so that you are able to understand what our pelvic floors do. Finally, we'll transition into talking about signs of discomfort, signs of dysfunction, and the help that's available. So there will be a lot of information about professionals that you can reach out to at the end as well. As a disclaimer, we do have 2 medical and health professionals, and for the purposes of this educational webinar, medical advice can't be provided. If you are asking questions, be aware if you're providing too much historical context and history, and know that both of them are available by email to reach out to outside of this webinar. We just like to respect the confidentiality of this space and give everyone a chance to have their questions answered. And so before we begin, as Muslims, we always hear that intentions are really important. So we wanted to offer you all a chance to think about, like, what brought you to this webinar? What information are you hoping to learn? And what are you hoping to leave with? So this isn't something you have to write down. It's just something to really bring to the forefront of your mind. And we're hoping that we would answer your intention by giving you information. So just a way to kind of frame you moving forward. So there's a few ways that you can ask questions on this webinar. You can direct message me. I'll be monitoring the chat while the 2 doctors speak throughout the webinar. You can also type in your question to everybody in the chat, knowing that they'll see your name when you do that. And then lastly, towards the end, if we have time, we may be able to use the raise hand feature if you'd like to ask your question verbally. So those are just some options for you to be able to engage. All right, so I'm going to speak briefly about sexual health for Muslims in terms of the field itself, and wanted to start by really grounding us in our Islamic tradition. So sexual health is something that God has given us from when we're born. It is a very specific and sacred part of ourselves that we have. And our reproductive systems, our pelvic functions, and our sexual health all develops as we grow and develop. And this sacredness of our body, because we only have one from birth to death, means that we are entrusted to take care of it. That includes all aspects of physical health, from getting a cold all the way to experiencing dysfunction or issues with our pelvic health. And sex is only one part of sexual health. That word often gets misassociated, and people worry that, oh, if it's only sex, why are we talking about this early on? And sexual health is foundational to have sex when it's a part of your life. Pelvic health and understanding your pelvic floor is foundational to engaging in pleasurable, pain-free sex. So we want to make sure you all have foundational skills, regardless of the stage of life you're in, because the more you know ahead of time, God willing, you'll be able to realize when there's issues and you can, inshallah, get help before it gets too worse. And we know that sexual health is tied to God consciousness. If we know more about our bodies, we understand the way God created us, and this can really help us feel grounded in who we are as Muslims and that identity. And so if we talk about sexual health, and as we move through the content, please remember that sexual health is tied to physical health, it's tied to mental health, and it's tied to spiritual health. So we're really focusing on not only learning about our bodies, but also tying it to other aspects of our well-being too. So why is this information important? Like, why should we learn this? Well, developmentally, we know that sexual health information will be used later on in life, so we want to be able to learn it as soon as we can. Oftentimes as Muslims, if we're lucky, we learn what the word vagina and penis, sometimes nicknames, which is not helpful. And if we're not lucky, we don't even learn this. So we are really limited with information, and we see this. Muslims really struggle with sexual health and pelvic health literacy, understanding their bodies. Ideally, what we should learn is comprehensive, which is what today's about. Sexual health and pelvic health are really tied closely together. And so before we're sexually active, we've learned information about our health, wellness checks that we should do with our bodies, how to understand them, and possible signs of dysfunction. So these are all really important reasons for Muslims to learn this information. So let's see what happens when we don't learn this information. And we know this as Muslims, we've experienced shame and stigma. There's a really deep sense of shame and unworthiness when it comes to sexual health. We have such a hard time talking about it and unlearning. Oftentimes, Muslims struggle with issues without support or knowing where to go. We have seen, all of us, how sex and intimacy gets impacted during marriage because of pelvic floor dysfunctions. We also know that impacts mental health. We want to be a sexual being in marriage, and a lot of times pelvic pain and dysfunction disrupts that. And then we also accept common myths that are really harmful. And we're going to go through that briefly on this final slide of this section, because both doctors will be speaking about these myths as they go through pelvic floor information. So first of all, myths means that they're not true. So everything on this slide is not true. For example, sex for the first time will be painful and that's all right. That is not true. Sex should not be painful the first time or any time. We have to kind of unlearn what we see in media and what we learn from our families, and that's really important. Virginity will not be taken away by tampon use, pelvic exams, pap smears, and even self-exams, right? Virginity is a social construct that has no place in Islam. There's no scripture about it in terms of hymens and tampon use and anything to do with the pelvic floor. That also means that women do not necessarily bleed the first time they have sex, and they'll be speaking more about the hymen and why that is. And so this is really important, that this is not an Islamic scripture or Islamic tradition. This is completely patriarchal and not rooted in Islam. The notion of patience in Islam does not mean sitting and quietly enduring pain and waiting for God to intervene. Patience in Islam is an active verb. It means you do what you need to do, tie your camel and ask God for support. So by coming here, you're all doing that. You're doing active patience, you're doing something. And also, let's completely debunk the myth that men have more an Islamic right to sexual pleasure than women do. We know in hadith, stories from the Prophet's time, that actually female pleasure comes first in marriage, that wives need to be pleasured first before the husband is. So these are all myths that we hear, and you may hear if they be debunked more as we go through the content. And from now, I'm going to pass it on to Dr. Samhouri to begin with the pelvic floor.
Thank you, Samira. So this is just a visual of what we are looking at when we take a mirror down there, which I highly doubt anyone really ever does prior to marriage. And just to get an idea of what this region looks like. It's our vulva, it's our vestibule, it's our introitus. So this is just kind of a little label gram to show you what you have down there, and that we have 3 holes down there. Unfortunately, many women don't know that. But we can go to the next slide. So what is the pelvic floor that we refer to? The pelvic floor refers to a group of muscles that attach from the front and back. I actually have a pelvis here to show you, that attach from the front and back and the sides of the pelvis, all the way from the pubic bone to the sacrum, and create like a sling or a hammock, right? So you can see that. And the job of this hammock is to carry all of our reproductive organs and our bladder, our uterus, our rectum. And the job of these muscles is to make sure that they don't, one, fall out of our body, and wraps around the urethra, rectum, and vagina to make sure that we don't pee and poop our pants. Next slide. So the pelvic floor consists of muscles, ligaments, nerves that are all responsible for the functions of these organs, as well as the muscles in here. So lots of intricacies in this little region here. Nerves actually come out from the spine here, and they dive into the pelvic floor and take care of all of these organs. They're also responsible for trunk and pelvic stabilization. So the continuation of our pelvic floor muscles would be our core muscles coming up this way. So a weak core, especially you can consider, postpartum, a very weak core can also contribute to a weak pelvic floor and possible prolapse. Their job is also, like I said earlier, for sphincteric strength. So making sure that our urethra remains closed, our rectum stay closed, so we can decide when we need to use the bathroom, as well as the lymphatic system. So sometimes these things malfunction just like any other muscle in our body. Next slide, please. This is a great sagittal view. This is a side view of how these organs share space in this cavity. And you can see they're all pretty much on top of each other. So of course, one affects the other. They're all neighbors. You can't address one without addressing the others. You can see the bladder lives right in front of the uterus, which lives right in front of the rectum. So any one of these having an issue will definitely create a dysfunction for any one of these other regions. I think Dr. Ahmed wants to take over the slide.
So as Dr. Samori was saying, there are superficial muscles and there are deep muscles. And when you're having entrance pain with intercourse, there are certain muscles in the front that may be bothered. And these superficial transverse perineal muscles, we don't need to get too deep into the names of them. And then there's muscles that go from the pubic bone to the tailbone, and then the pubic bone to the rectum. And they're called pubococcygeus, puborectalis, and the iliac bone, which is the bone. If Summer shows the pelvis again, you can show her the iliac bone. And they go, and that's the iliococcygeus. So as she said, there's these deep muscles that are layered on top of each other. And then there's the superficial muscles that are the ones that will, be very closely related to the urethra. The clitoris is above it. And then the vagina, well, the vulva is the entrance, and then the vagina is the canal that's within it. So often people are referring to their vagina inappropriately. It's actually the vulva, which they most likely are talking about, and not their vaginal canal. And then the rectum or the anus, most of these muscles do connect to it, which is why sometimes you may see the term levator ani, which is similar to the word anus. So that's why people often think of it related to the rectum or the anus, and not necessarily to the genitals. And so as Summer was saying, if your muscles are affected one way or the other, whether they're loose or tight, all of these three holes will be affected. And so when muscles are tight, what can happen? Muscles can squeeze on nerves, and in every part of your entire body, there are nerves. There are superficial nerves, which are the ones that are on your skin that make you feel when someone touches your arm. And then there are deep muscles that are motor in function. So those are the ones that help you walk and help you raise your arm up or move your body. So when people have pain, sometimes they're more the superficial nerves. And depending on where your pain is, there is an ilioinguinal nerve that comes up to the sides of your groin, going from what people feel, to the sides of their belly button. And then there's a genitofemoral nerve, which goes right over your pubic bone and goes down to your leg, because the femur is a fancy word for femoral. So it goes down your genitals and down your leg. And then there is this posterior cutaneous nerve of the thigh, which sometimes in pregnancy can cause problems. Part of this nerve, because as women gain weight or their fluid levels shift, they can have an increase in pressure and on this nerve, and that can cause pain. And then the major nerve of the pelvic floor, which is the pudendal nerve. The pudendal nerve has little tiny branches that go to the anus, that go to the perineum, which is the area between your vaginal orifice, the entrance of your vagina, or the introitus, which is where you have intercourse. And then also it goes up to the clitoris. There is a branch there. So this pudendal nerve is usually quite often Googled, and a lot of people are looking up this nerve because they feel like it does relate to a lot of why they're having these symptoms. And we can go into, we'll talk more about nerves at some point later on. But that's just a basic view of the 4 major nerves of the pelvis. And then next slide. Summer.
Okay, so the functions of the pelvic floor. So what are the pelvic floor muscles responsible for? They're responsible for controlling our bowels and our bladder, making sure that we urinate when we're supposed to urinate, or hold the urine in when we can't make it to a restroom right away, or or a fecal, or having a bowel movement, being able to hold in our bowels if we can't make it to the restroom. And then, of course, when we make it to the restroom, being able to empty properly. These are the responsibilities of these muscles. Their muscles are to be, their job, their function is to be strong and stable. So not only to carry these organs, but also to create support and keep these openings closed. However, their job is also to be able to be flexible. So we can have a bowel movement, so we can have intercourse, so we can have a baby. So they have to be strong and long. So a stronger pelvic floor will help reduce your risk of incontinence, meaning, urinating or leaking, improve your sexual health, and boost your core stability, core strength and stability. Next slide, please. So we have to have considerations, not just for women that are pregnant, women that are postpartum, but also women as we age. So throughout our life, we're going to be very dependent on these muscles to maintain their strength. With menopause, the ovaries stop making hormones such as estrogen and progesterone. Estrogen is the hormone that actually keeps these muscles nice and plump and lubricated. And without estrogen, post-menopause, or even during pregnancy, when we're not getting a period, these muscles become a little thinner, a little drier, less elastic, and sometimes sex becomes very painful due to these changes. Sometimes we even experience incontinence or urinary leakage because of these changes. Your risk of vaginal yeast infections increases. Other common changes include low sex drive or low libido and reduced response. A lot of women will say, I can't quite orgasm as strongly as I used to. And it's because these muscles are a lot weaker. The urinary system changes, such as frequency and urgency. So not just losing your ability to hold in your urine, but also feeling like you have to urinate every 20 minutes, or not being able to hold it through a car ride, or just leaking every time you feel like you have to urinate, you don't get a chance to hold it in. All of a sudden the muscles are releasing out of your own control. Also loss of tone in these muscles resulting in vaginal, uteral, or bladder prolapse, meaning there's a pressure in the pelvic floor, feeling like things almost want to come out of the body or fall out of the body. A lot of women will come and complain and say, some things just feel like they're pressing on my opening and want to leave my pelvic floor. So that's a prolapse. And unfortunately, a lot of women think that the only way to take care of that is surgery, and that's not true. So we'll talk about treatment later on. Next slide, please. So dysfunction, this is when we talk about the different things, obviously, that can happen. So this may seem kind of redundant, but the main disorders that can occur in the pelvic floor are urinary incontinence or lack of bladder control. A lot of women will say, oh, every time I sneeze and cough or laugh, I leak. And even though that's very, very common, it's not normal. It's still not normal for that to happen. Fecal incontinence, feeling like I can't hold it in. I have bowel leakage out of my control. Or pelvic organ prolapse, meaning your organs feel like they're dropping to the bottom portion of the pelvis or coming out of your body. Childbirth is one of the main causes of pelvic floor disorders. A woman's risk tends to increase every time she gives birth. So of course, it's a very traumatic event for the pelvic floor muscles. So as she pushes out a baby, these muscles are lengthened, sometimes torn. And so it increases their risk of pelvic floor disorder or even yanking on some nerves or ligaments, as we mentioned earlier. Women who are overweight or obese, same idea. There's a lot of pressure on the pelvic floor. If women are overweight or obese, they have a greater risk of pelvic floor disorders. Women who have any kind of pelvic surgery can damage nerves in the pelvic floor, meaning hysterectomies or any kind of oncology related or cancer related surgeries in the pelvic floor can also experience pelvic floor dysfunction. Repeated heavy lifting. A lot of people are not aware of contracting the pelvic floor to protect them while they lift. So they'll create a lot of pressure every time they lift something heavy. So if that's part of their job duties, or think about your typical housewife. Lifting a load of laundry sometimes can be that heavy. Lifting a car seat, lifting a stroller, putting it in the car, lots of heavy lifting can cause pelvic floor prolapse, as well as genetics. A lot of women are sometimes just genetically inclined to having prolapse. Someone will say, oh, my mother had a hysterectomy, my grandmother had a hysterectomy, and every woman in my family eventually has a hysterectomy. Well, these are things that can also cause disorder. Next slide, please.
So I'm gonna just go into chronic pelvic pain. So before I do that, I just want everyone to understand the difference between the two different types of ways patients can present. and this is going to be very, very basic. What I tell my patients are, there can be the very tight and weak pelvic floors that are so contracted that they cannot lengthen, as Summer said. And those women, some women, I can barely get my finger in. And I might call that person a 10 on a 0 to 10 scale. And I'm not trying to make anyone feel bad or anything. I just want just a very basic understanding. And then there can be your grandparent who's in a diaper because they're having urinary leakage and they cannot control their leakage. And that, maybe we call that a negative 10. We want patients to be kind of like at 0. Typically patients who are in the -2 to +2 aren't seeking help because their symptoms are mild and they're not necessarily needing any assistance for any problems. But that being said, if you're having a 5 out of 10 tightness and you're having pain with sex, patients typically present with pain. And if you're -5 where you might, or -3 where you might be sneezing and coughing and having some leakage, but not enough leakage for it to bother you, maybe at that point, you may not be seeking attention. So there are 2 separate, very separate subsets of people that are seen. In my practice, I see both subsets. In Summer's practice, she also sees both subsets. So, but the treatments are very different. And that's the most important thing to take away from this. If you have a tight pelvic floor, you cannot treat it the same way as having a loose and weak pelvic floor. In both scenarios, the pelvic floor is weak. In both scenarios, they are not strong. The person who is strongest is actually at 0. Their pelvic floor is holding all of their organs without any problem. The ones here are so tight, they're having trouble with urinating and having trouble with putting a tampon in and having trouble with having bowel movements and constipated. And in this person, they may feel the fecal incontinence, the urinary incontinence, and they may feel really loose during intercourse. And pregnant women don't always fall in the loose category. Sometimes pregnant women can actually fall, postpartum can fall in this category as well. So if you feel like, I just had 2 babies, why am I having pain with sex? It's what I call a mixed bag of a little bit of this and a little bit of that. And so if you guys understand that, I think then you'll understand. Majority of my patients come for this because typically they don't present with pain. And a lot of people, because of all the myths that Samira was talking about earlier, they feel like there's nothing they can do about the urinary incontinence. And that's not just Muslims, that's everyone in the world. That I can live with a little bit of urinary urgency or incontinence or a little bit of leaking of my stools. And you don't have to live with any of these. You should be, seeking treatment for both subsets. Okay, so chronic pelvic pain, it's persistent, it's all the time. It's not necessarily cyclical or non-cyclical. For some patients, it can be related to their menses. Some people, it's not often discussed. And many patients are very frustrated when they come to see me because they've been to their gynecologist, they've been to the urologist, they've been to their GI doctor, and they're saying, I'm having urinary frequency and I feel like I have a UTI, but every time you test me I'm negative, or I took the antibiotics, why am I not better? So I work with a lot of these specialists and we try to figure out what's going on. And it's in only the last 10-20 years has it started to be a topic that people even discussed. It was never even really discussed before that. You just kind of lived with it. And these set of muscles, many doctors that are older don't even really address them or consider them that important. But we've now realized that these muscles are just as important as your bicep or your core muscles. As Summer said, your core is connected to your pelvic floor. So understanding the connection, and I often deal with neurologists, pain management, colorectal, as well as rheumatologists who help to find out if there's any conditions that you may have genetically that could be causing any of these conditions. Next slide, please. So the chronic pain cycle, very simply, there is typically, I start off at the mechanical change. So for some women, it could be a fall on their tailbone. For some women, it could be a pregnancy, or they have endometriosis, which we can get into in a few minutes. For it could be any condition. They could have hemorrhoids. They could have urinary, like they could have cancer. Whatever mechanical change happened, whether it's abuse, whether it was something changed. Maybe they fell, and maybe they have hip pain. Maybe they have, basically anything that could possibly change in their situation. They could have had a trauma in their life, a job change, the pandemic, really anyone who's now changed something in their life. And all of a sudden now, these muscles that we've talked about are going into spasm. And when muscles go into spasm, they become very tight. And when they become tight, those arteries and veins that travel with those nerves, they travel together. Anywhere in your body you have nerves, you have arteries and veins. And their job is to oxygenate the muscles and everything around it. And so if those arteries and veins are not having that circulation, what happens is the pH drops. The pH now becomes more acidic. Now an inflammatory response happens. So your body starts to feel hot and bothered. And what normally your body's own inflammatory response is there to help you, it's now not able to do that. The muscles are weak, like we said, right? They're contracted. They're not doing the expansion they used to. And now they're doing this shortened one. Those yellow nerves, which we didn't talk about, but I showed you some nerves. They are irritated. Those are the nerves that come from your spinal cord that go into your pelvis. They're irritated. They now tell your brain that, which is your central nervous system, that your brain and spinal cord, that this is your new normal and this is how you're going to live. And when you've been in pain for more than 6 months, your body starts to regulate as this is my new normal. And it's hard to come out of this. And that's why treating patients with pain is very difficult, because you have to treat the mind, and not that it's a psychological problem. It's actually in the brain and in the spinal cord, and your body can't respond the way someone who's not in pain responds. And so I often tell my patients, if I punched you in the shoulder, you're going to have a response. But if I punch someone who's got pain chronically, their body doesn't respond the same way. And so understanding that chronic pain is not just a 1, 2, 3, why can't I take a medicine and it'll go away? There's a lot of things that need to be treated, the muscles, the nerves, the bones, all of that together. And you can come in and out of this cycle in so many places. So if you're having increased inflammation and it's in your pelvis, now if you start standing on one side, you might start developing hip pain. And if you start developing hip pain, your muscles on the opposite side might start having to compensate for that. And so those muscles might start to hurt. And so it goes back and forth until you really treat the root of the problem. Next slide. So just very basically, we're going to talk about a couple of areas of pain. So the musculoskeletal symptoms, so that's the bones, the joints, the nerves, that's what I do as a physiatrist. I treat those. So a lot of people are always confused why I treat urinary and sexual pain, but because I treat muscles, joints, and nerves, I just happen to treat the pelvis. So the tailbone is, the fancy word is coccyx, the buttock pain, that's the muscles in that area, the abdomen, the abdominal pain. You might present with groin pain, which is, a lot of people confuse it with hip pain. That's basically between that top area and the pubic bone. And Summer pulls up her model, you can see, but essentially the groin is basic, turn it around, right from the top of the ASIS down to the pubic bone. And then patients can have hypermobile joints. So what is a hypermobile joint? Hypermobile joints are, your joints are hypermobile, and we often say because your joints can't, they're so loosey. They're so loose that the muscles now have to compensate for that. And now they start to get very tight. And that's why, it's not good to have tight muscles, right? Because we just said that they're weak when they're tight. Patients may have hip pain, and we know that the hips are right in your pelvis. So that's also very closely related. So if patients are presenting with hip pain, they might not recognize that, oh, my hip pain is causing my pain with sex, or if I don't fix my hip pain, my urinary symptoms, that they're all connected. So fixing some of those problems will address some of the other problems that you may not tell your orthopedic surgeon about. Oh, when I have hip pain, you might not say I also have pain with sex. So unless someone, takes that whole full picture of what's going on, you may miss these things. Your SI joint is actually in the back of your pelvis. It's between your sacrum and your iliac bone. And if you Google SI joint, Summer, say something so you can show it, because otherwise your voice.
Oh, sorry. So this is the back of the pelvis, and the SI joints are where the sacrum and the iliac bones meet.
Perfect. So now in terms of pain with sitting, people can have pain with sitting. And so now that we're in a pandemic, I see a lot of this. When you're sitting directly on your pelvic floor, those nerves we talked about can be irritated, and constant sitting, a lot of traveling will put irritation on those nerves. People may present with pain with intercourse when it's with first entrance, with deep penetration. So understanding that there's two different types of pain when you're having intercourse, whether it's with entrance or whether it's with deep thrusting, whether it's with certain positions. Patients can have an inability to orgasm or pain with orgasm. They can also have something that's very not often discussed, a persistent arousal. And it's very taboo to talk about arousal because this makes it sound very sexual. But when you have a persistent arousal that's actually not sexual, it's a disturbing, it's uncomfortable, and nobody wants to be aroused all day long. So, discussing that as, Googling that, you might actually find better luck Googling persistent genital arousal if you are experiencing this, versus speaking to some gynecologists don't even know what this is. Then you can have vulvar pain, which is the outside, vulvar itching, and then pain that's heightened with menstrual cycle. And there's way more. I could have added so many more symptoms. And if you have any symptom down there, you would consider that a pelvic pain symptom. But when you have pain that's, all month long or just with your period, sometimes people don't realize that it's related to their period because it's not with their period. So maybe it's the week before their period, during the week of the period, and the week after their period. And they don't realize that that actually is not normal. But usually if it's worse with your period, that's also a huge red flag that there is something going on. And we'll get into what that something is. There's urinary urgency, urinary frequency. So understanding the difference, urgency is feeling the urge to urinate. You may or may not actually urinate. A lot may not come out. There's urinary frequency where you actually urinate. It might be small amounts, and sometimes patients will tell me that they go to the bathroom every 45 minutes, every 30 minutes. They can't stop. There's also often people complain of weak stream. They don't feel like they're getting it out fast enough or the way they used to. And if a 25-year-old is saying that, we know this is not something related to age. That's not appropriate, right? And it's not really appropriate except if there's like a prostate involved, and that's not involved in this situation. There's a sensation of not fully emptying. So many patients will say, I don't feel like I fully emptied. So now I have to go pee again, but when I go, there's not a lot coming out. And that's something we'll talk about in treatment. Urethral burning is also a very common complaint. And then rectal burning, rectal itching, numbness at the rectum, feeling like they're sitting on a golf ball, or that pressure of something coming out of their butt. Pain that's worse with the bowel movement that may be relieved by a bowel movement, and some feeling like they don't fully empty their bowel, or they're having chronic constipation, or they feel like they're constipated. And then the incomplete evacuation is on their choice. Next slide. So possible causes. I mean, I could probably spend an hour doing this, but very quickly, adenomyosis is something that's in the uterus. And typically the treatment for that is a hysterectomy. And that's not something you can do when you're a child, if you want to have a child. So there are different procedures that can be done to avoid having a hysterectomy, but the gold standard typically is a hysterectomy. But please do not, if you have this diagnosis, go straight to a hysterectomy, because if you want a child, there are different solutions that could potentially help. Endometriosis, which is 1 in every 10 women, it's so underdiagnosed, especially within women and people of color, that I probably started my Instagram because of endometriosis. 1 in every 10 women has it, and they think that having painful periods is normal, and painful periods is not normal. With women with endometriosis can be diagnosed clinically, and they can be diagnosed officially by surgery. So that scares people. And so because of that scaring people, people are scared to know. And I always say knowledge is power. I think there's a wonderful book out there, Beating Endo, by Iris Orbach. Maybe Samira can put it in the chat. If anyone thinks that they have painful periods and they're concerned with maybe their periods are not normal, you should not be debilitated by your period. You should not be in so much pain that you have to go to the hospital, that you go to the ER, that you are vomiting, that you're missing school or work due to your period. If you're the week before and the week after, and you're not realizing, that can all be related to something called endometriosis. And that is tissue that seems like tissue in your uterus that is now hanging outside of your uterus. So it can be on top of the bowel, on top of the bladder, on the pelvic floor. And that can be causing a lot of the issues with painful sex and constipation and urinary frequency and urgency. So it gets confusing, because many patients can have pelvic floor dysfunction. And so very quickly, pelvic floor dysfunction is a very big umbrella for people with hypertonic pelvic floor, the overactive tight, and the hypo underactive loose muscles. And the endometriosis and the adenomyosis, those typically come under that right side. So when patients have pain constantly from any of these conditions, they will now present with pelvic floor dysfunction very often, because their muscles, what your body's response to having pain is to tighten up and crawl up into a ball. And those core muscles are being tightened, and that's now affecting your pelvic floor muscles. And so that's why we often see pelvic floor dysfunction side by side with all of these conditions. And so anyone who has any of these conditions can also present with pelvic floor dysfunction. And any of the next few slides I'm going to say, the same thing goes. Lichen sclerosis is a skin condition. Ovarian cysts are cysts on the ovaries. Ovarian remnant syndrome, which is not as commonly seen. Pelvic adhesions is when you can have scar tissue or adhesions within your pelvis secondary to having previous surgeries. Pelvic congestion syndrome is when the vessels might not necessarily be full flow. Think of your stream, your blood vessels, if they're kinked and now you're not getting your vessels there, so the blood down to where you need to, that can be called pelvic congestion. So varicose veins in your legs, similar to that, but just in your pelvis. Pelvic inflammatory disease typically happens when you have multiple or repeat infections in your pelvis. And then varicosities, which we kind of similar to the pelvic congestion. Postpartum trauma, women postpartum often think, oh, well, I have to live with this. I had some trauma postpartum, but very often there's a lot that can be done postpartum to treat patients who have pain after delivery. And patients like to compare themselves to their sisters or their friends and say, well, you're not having any pain, then there must be something wrong with me. And that doesn't mean that you're not, there's something wrong with you. Everyone's birth story is completely different. And so no single person is exactly the same. And so if you have a tear and your friend had a tear, and why is she okay, but I'm not okay? Your life stories are very different. You might have a history of endometriosis and she may not. You may have, there's just so much that you can say. You may have fallen off and broken your tailbone when you were bike riding at some point in your life. There's so many differences in your life. So always reach out even for postpartum trauma. Persistent genital arousal, which we quickly mentioned, that was it's not normal, it's an abnormal experience, and it's not a fun experience. Polycystic ovarian, PCOS, which is also something that, often people are saying, doctors will say, well, you might have PCOS, you might not, lose some weight, and people aren't always encouraged to do the things that they need to do, which can, and these PCOS can affect fertility, which is one of the major reasons why it's so important to know whether you have PCOS or get an idea of it and what you can do to help yourself to treat it, because there are so many natural ways to treat this so that you can have responses. Your body can respond. And I can go literally on these topics forever and ever. So I'm going to try to move a little bit faster because for the time. Recurrent yeast infections can affect the pH in the vagina. And there are things you can do like suppositories that you can put in to help reset that pH. Salpingitis is essentially having an infection of the fallopian tubes. The fibroids they're typically non-painful, but people don't realize that there are fibroids that do cause pain. And so those can be removed as well. Vaginismus is a condition where people can have an involuntary contraction of the muscles right before something's about to enter. So it can be caused by multiple reasons. There's primary vaginismus and then secondary vaginismus. Primary vaginismus is typically the first time anything is entering the vagina, whether it's a tampon, whether it's the first time you're trying to have penetration, whether it's a finger, and whether it's a pap smear. It doesn't matter. Many times patients will have a psychological response to it. There can also be a secondary vaginismus. So you can have had a normal, penetrative sexual history before, and now all of a sudden something traumatic happened to you, and now you're having secondary vaginismus, where now nothing is able to penetrate. And that's something that can also be worked on. So there's understanding the diagnosis and how that's different. Patients typically with pelvic floor dysfunction will also call, say, oh, you have vaginismus, your muscles are tight. But for those patients, there typically is a more psychological component to it, because they're dealing with trauma, or they're dealing with something, just anxiety. And a lot of Muslim women are struggling with this, because we're raised not to talk about intercourse and raised not to think about sex or know about sex. And so this is why it's so important to understand and not, and explore in a safe and Islamic way to do that to your body, so that you're not living with this. I often see patients who complain to me that my parents always did this, but my sister can have intercourse, but I can't have intercourse. And we're all separate human beings. We're all different. And our responses to the way we are raised and the way our brains work are all different. So don't put the blame on yourself. And then vulvar syndromes, which could be like vulvodynia or vestibulodynia. Those are specifically pain in the certain areas of the vestibule or the vulva. And then the chronic yeast apparently is on their choice. Next slide, please. GI, like I said, all can cause pelvic floor dysfunction, having chronic constipation. And that a lot of people don't even understand that chronic constipation is actually, people think, oh, I have a bowel movement every other day. But if the bowels are coming out small pellets, look like little rabbit pellets, that's not normal. We're aiming to have nice long stools. And if you ever have questions about that, there are stool charts, and it's not actual stool. If you type in onto Google, Bristol stool chart, maybe Samira can put that in as well, you can see what a normal stool looks like compared to a constipated stool. So 1 and 2 in the stool chart would be constipation, 3 and 4 is more normal, and then beyond that is more diarrhea. And we want to try to stay in the normal. And there are different things you can do to that, like dietary changes, adding water, adding fiber. But when people have tight pelvic floors, their muscles are not allowing them to have a bowel movement. So that muscle, that puborectalis muscle I mentioned, goes from the pubic bone to the rectum, and it holds it like a slingshot. So the poop is trying to get past, but it can't. And it's so tight. Now, if you have little pellet stools, it causes an increase in density. And because of that, it feels like you're full, but when you go, only small little pellets come out. And so there is a disconnect between the brain and what's going on down there. Diverticulitis is a condition that can affect the colon, and that is mostly dealt with a GI gastroenterologist, but it can affect pelvic floor. And hemorrhoids are usually what typically appear. They can be internal, external, when patients have too much pressure trying to have a bowel movement, or during delivery or during pregnancy. And so learning how to do some diaphragmatic breathing, which we can try to talk about if we have enough time, so that when you are having your bowel movement, you're not putting too much pressure on your pelvic floor. Using a step stool or squatty potty or squatting like back in the old days can help prevent that, because we don't want to increase the pressure when we're having our bowel movements. Inflammatory bowel diseases like ulcerative colitis or Crohn's, which which are already on this list. So the Crohn's and ulcerative colitis, those are both conditions of the colon, similar to diverticulitis, but they're autoimmune conditions. Proctalgia fugax is having contractions of the muscles around the anus, basically, and proctitis is inflammation, and then irritable bowel syndromes, which is often labeled, and many patients are often labeled with IBS or irritable bowel when they may have endometriosis or one of these other conditions, when kind of a diagnosis of exclusion, when they don't know what it could be. Many patients are often told that they have IBS, and they might have IBS constipation or IBS diarrhea. Musculoskeletal sports hernia, which is not a true hernia. It's actually a tear, which is near the pubic bone, and many patients will feel pain around their pubic area. Many patients, when they're pregnant, they might feel pain in their pubic area just with the way their pelvis is widening, because they have to hold a baby in there. And that's not the same thing as this. That would be the osteitis pubis, which is the fifth one down. So but that sports hernia is typically something we see after sports injuries. But that being said, many people who don't necessarily have sport injuries can have a sports hernia. Tailbone pain is the coccydynia. So many patients who sit on hard seats all the time, or if they fall on their tailbone, or they're skiers, or they are horseback riders, we see a lot of that, or just having tight pelvic floor muscles that are now moving the coccyx, and that tailbone isn't where it's supposed to be, and it's not as aligned as it should be. That can cause a lot of tailbone pain. And of course, postpartum myofascial pain. So you can have muscle pain in your legs. So anything I say is fair game between your knees and your belly button. Any pain between your knees and belly button causing any muscular pains can be related to your pelvis, because it can cause referred pain up and down. Piriformis syndrome, that's the muscle that's if you touch the one spot right in your glutes, in your butt, you often feel some soreness. And so when you do a move, if you're into yoga, the pigeon pose or a figure 8 stretch, you'll feel that piriformis muscle. So there's that can like I said, any muscle that's tight it can cause the pelvic floor to cause pain, right? Because your bicep is connected to your tricep. So if your bicep has a problem, your triceps is not going to just say, well, there's a barrier here, I'm not going to be affected. It's the same thing. So anything in your hips, your butt muscles, your leg muscles, your upper thighs, your belly button, they all connected. So your SI joint, and that's another what we showed you previously, and then labral tears, which are tears in your hip capsule, can also cause problems, because if that capsule is torn, it's your shock absorber, and that's the muscle, that's the cartilage that's protecting your hip joint. And now if you have an injury to it, it can make the rest of your muscle have to compensate, like we were talking about before. Next slide. Urologic. So there's a lot of symptoms or syndromes that can cause this. For women, we're just going to talk about interstitial cystitis. So that's a condition in the bladder. To diagnose it, it's usually done by a urologist, and they take a camera into your urethra and look and see inside your bladder. It's such an ambiguous diagnosis and often misunderstood. And many times, I forget what the stat is, many times I see as improperly diagnosed for what is just pelvic floor dysfunction. So understanding that you may or may not necessarily have it, but I always feel firmly that we treat the pelvic floor, then your urinary symptoms, if they improve, great. And if they don't, but other symptoms are improving, then we can now look and see if there's something going on in your bladder. An inguinal hernia is a hernia, which could be fat, it could be bowel, it could be many things. But if it's pressing on the nerve in the inguinal region, which we quickly discussed earlier, it can cause pain in the groin, and that can be very easily surgically removed or treated with injections or creams, and depends on the situation, but typically an MRI is needed to diagnose that. We're going to skip prostatitis. A transvaginal mesh complication is usually when someone has a surgery to fix a problem and now they're having pain. That's a complication of that. Urethral diverticulum is a little bit more complicated. It's within the urethra, and we're not going to get into that. Testicular torsions for males, and recurrent UTIs. When people complain of having recurrent UTIs, oh, I just had one, and then I had one again, and then it wouldn't go away, and I kept going. And if you're not necessarily culturing your urine, if your doctor is not culturing it, and then they're starting you on antibiotics, or you're asking for antibiotics because you're in so much discomfort, if the culture is coming up negative, many times pelvic floor dysfunction can mimic a UTI, and it can make you feel like you have a UTI, that urethral burning or frequency or urgency, and it's actually just pelvic floor dysfunction, and that's why we treat the pelvic floor dysfunction before. But I would always go to your urologist or your primary care doctor, get a urine checked, get the culture checked, and before you start the antibiotics, wait to see what comes up on the culture. And I understand if you've never had a UTI, you can always have a true UTI, but the most important thing is to treat the true ones and not the not true ones. Then the neurologic conditions, chronic regional pain syndrome, that's when you've had pain for so long, it can cause a syndrome. Kind of like having chronic pelvic pain. Genitofemoral neuralgia is having pain in the distribution of that genitofemoral nerve. Same with iliohypogastric neuralgia and all of these are basically saying pain in those distributions of those nerves. Migraines, a lot of patients who have migraines have pelvic pain as well. Pudendal neuralgia is that pudendal nerve we talked about. And then radiculopathy, that typically comes from your lumbar spine. And many people start off when they have pain. Maybe I'll go to my primary care, and my primary care doctor is saying, maybe it's coming from your back. And we always want to look and check and see if it is coming from your back, because if it truly is coming from your back, it can go down your legs. But pelvic pain can also refer down to your legs and not necessarily come from the back. So it's important to distinguish the difference between whether you actually have a true radiculopathy that's coming from your back, and that's done with a lumbar MRI. Next slide. Oncologic, inshallah, or like none of you have to deal with this, but cancers can cause and radiation can cause issues with your nerves. And when it does, it can cause issues in your pelvis. Rheumatologic fibromyalgia, patients with fibromyalgia when it's having a lot of muscular or tender points all over your body, and so your pelvic floor is not exempt from that, and you may have trigger points or areas in your pelvic floor that cause pain. Ehlers-Danlos syndromes are conditions. It's a genetic condition that's not often diagnosed because the genetic testing is not necessarily available for patients. And these are the ones who are having those hypermobile joints, and their muscles are having to compensate for them. And these people present typically very hypermobile. Maybe their shoulder pops out, their hip pops out, or they feel very elastic and very flexible. It's very different than just touching your toes. That's not the type of flexibility that I'm talking about. It's being overly hypermobile. And then the rheumatoid arthritis, because patients with rheumatoid arthritis can also present with psoriatic arthritis or different like spondylopathies. They can have sacroiliitis, which is that iliac SI joint that we saw on the bone is chronically inflamed. Next slide. So first line treatment. I'm just going to go through these. So pelvic floor physical therapy, and Dr. Samori is going to go over all of that in right after we finish this slide. It's my first number one. I always send all of my patients to all of pelvic floor physical therapy if they have access to it. If anyone is from outside of the US and they are not able to access pelvic physical therapy, or they cannot find someone to do it in person, many pelvic physical therapists actually offer telehealth. So it's so important if you can't access it due to cost or due to location. Even just learning about it, there's different books written by different authors. Heal Pelvic Pain by Dr. Amy Stein. She's a pelvic physical therapist as well. And that's another resource that you can use. There are different modalities that pelvic therapists use. Sometimes they use a TENS unit, which is very inexpensive and you can buy on Amazon. There's ultrasounds that are used during pelvic physical therapy for treatment of pain, not for diagnosing, or also for diagnosing and looking at the bladder. Lifestyle modification. So if someone is presenting with pain and they're saying, I've been sitting all day, well, I might recommend that they get a standing table. If they're not exercising because they've been lazy, or COVID is not, their gym's not open, I recommend starting off with 10 minutes of yoga daily. And really a lot of just lifestyle changes and trying to figure out what's going on in my life that's really causing problems. For people who are having the pain in the perineal area, that the cushions can help quite a bit. If it's tailbone pain, you can also get a cushion that's specifically to give you coccyx relief, to take the relief or the pressure off your tailbone. SI joint, when people are pregnant, they often present with that sacroiliac joint, and when they wear a SI belt, it helps support them. And when you're pregnant, it's one of the most common symptoms that patients will have. They'll have pain and they feel like their hip's gonna fall out. I remember having it and thinking, oh my gosh, but remember your body is growing. And so the belt has to be big enough to fit the growing you, because you're not wearing it around your waist, you're actually wearing it around your SI joint. And so properly wearing it is also really important. If you wear it improperly, it's not gonna help you as much. And then there's dilators and wands, which we'll go into more, and that can help with the pelvic floor dysfunction with the superficial muscles and the deep muscles. Oral nerve medications, which I'll also go into in a little bit, muscle relaxation medications that you can put in intravaginally or intrarectally to relax these muscles, help make things move a little bit faster. And sometimes everyone's in a rush to get better faster. And these are typically things I would do on my first visit. And then magnesium. I love that magnesium. I feel like it's a very underrated vitamin, and it's used to help relax muscles. It's helped to improve your bowels so that you have nice long stools. Many times I tell patients to look for foods that are high in magnesium, or just take a tablet or a capsule. There's also calm powders that you can buy on Amazon that you can add to your teas, and you can buy the non-flavored ones, or you can buy the flavored ones and add it to water, and it helps calm you down. It's also a great vitamin for headaches. It's good for muscle spasms, and it's, like I said, great for bowels. And then Epsom salts. Epsom salts are another source of magnesium that you can use. And if your muscles are so tight, when you take a hot bath and you feel better, you know that this is a muscular problem, and that's what you need to address. All right, next slide. Okay, Summer's not up yet. I'm up, but dilators. So very quickly, Summer actually has them. And so Summer, just say something so that.
So I have a few here that I have lined up. I don't know if I can get this to see all of my dilators. So they obviously come in different sizes. Dilators are used to help stretch the vaginal opening for women that are having pain with intercourse, or pain with a medical vaginal exam, or even just pain inserting a tampon, right? And obviously, you know, the goal is to be able to not just insert one, but to tolerate a prolonged stretch. And they come in different sizes, you know, size 1 all the way to size 8. This is just one style. And so obviously these come in different styles. But this is a device that women can use when they are having any discomfort with intercourse, as something that they can do at home for their own self-healing and self-recovery. There are different, this is a wand here. This is more for trigger point therapy for people that are having pain in specific regions in their pelvic floor. If there's just one spot that's causing radiating pain, or reproducing the pain symptoms that are maybe in the inner groin or in the low back, or something else can be found just using one of these devices. And of course, like Dr. Ahmed said, you can have, a telehealth session with a therapist. They can help you walk through it. Or a lot of these come with videos and pamphlets and information on how to use them. And so there's lots of these are Kegel weights, a whole other situation. This is more for strengthening, where these are more for stretching. So we talked about pain, and then we talked about weakness. So these are all the different kinds.
And Summer, would you mind just taking out dilator 1 and then just showing us the width of dilator 1? So dilator 1 is very thin. It's probably the size of my pinky. And so for someone who, if you turn it this way, they can see that it's very thin. And now you can show them dilator 8. That might scare some people, but dilator 8 is much wider. And the goal of using the dilators are to help stretch out the superficial muscles that are in entrance. And so it's going from appropriately. I've had patients go from dilator 1 to dilator 8 in 6 weeks. I've had patients do it in 1 year. I've had patients who don't ever need to go to 8 because their partner is not size 8. They can just go to size 7. And so it's important knowing what size your partner is when he's fully hard, so that you're not buying unnecessary dilators. Dilators 1 through, and you might find I can put dilator 1 in easily. So why do I need to buy 1 and 2? And 1 and 2, 3 and 4 are the small box. 5, 6, 7, 8 is the large box. But maybe you just need the medium sized box. So maybe you just need 3, 4, 5, 6. So those are 2 separate, there's 3 separate boxes. But you don't need to buy small, medium, and large, because the medium overlaps between small and large. And so a physical exam helps us figure out which size would be a good recommendation. And sometimes you might want to buy 3, 4, 5, 6, the medium box, but then your husband is actually size 7. And then I say, buy that one individually and work on that one. But you might say he's definitely not an 8, and you don't have to buy that one. So it's really about stretching. There are plastic dilators, which are more inexpensive. However, plastic Summer, show them how malleable.
So just to show you the difference in size, this is a 1, this is an 8. Clearly, we all need a different size, and you can see that they're very flexible.
So if you're using a plastic dilator, you're not going to have the same flexibility, and it's not going to feel as lifelike as when a penis enters. And there is there's way more give when it comes to a penis, because so very often if a patient's husband is a size 7 and they can get a 6 in, and then they have intercourse, they might find that works, or they might need to work on 7. It really depends on whether they're using lubrication, whether they're lubricated themselves, whether they're into it, whether they're mentally aware or spiritually wanting to do this, and so all those factors play a role in, and once there's a lot of confidence that I can get dilator 7 in by myself when I want to have intercourse. I know I can get 7 in, and then you go into intercourse. So I always say, don't really have sex or attempt penetrative intercourse until you feel like you can get the appropriate size in, because otherwise it starts to mess with your head, and you start to create a negative energy about intercourse, and now you're really making things harder for you. And so I always say, especially when I'm in treatment with patients, wait until you are ready, because trying to please a partner is not the goal of sex. It's the goal is to have a consensual, enjoyable experience. And just because the entrance is not a problem, there may be a pain with thrusting. So we said when he thrusts in and out, he may be hitting muscle. So Summer, if you take dilator 3 and put it into your pelvis, you can see how once she puts it in and you're replicating the sexual movement. I'll take the vagina off.
I don't think this one doesn't come off, unfortunately.
Oh, okay. Sorry, mine.
Darn it.
So mine goes in, and when you now turn it so that we can see the inside of the pelvis, when it hits, it's hitting the back of these muscles. And so when these muscles are now being hit, that can cause thrusting pain. And so just because he can enter doesn't mean you're gonna, why am I not enjoying intercourse when he's thrusting to ejaculate? Why am I not feeling good? And that means you have to work on the more deep muscles that are that might still be spastic. And if you're not going to physical therapy and you're not using suppositories, you have to, and if you don't have access, you will have to do this yourself. And that's when a wand comes into play. So next slide. So a wand, they come in different styles, and Summer will show you the green one. I like this one. It's also same brand, Intimate Rose. It vibrates. The purple one came out first. It doesn't vibrate, and it's more inexpensive. However, when you charge the green one, which I'm sure is not charged right now, it does vibrate. The purpose of it is to find the spots that are painful inside the pelvis and work them out. The original TheraWand, which is the top one, it's glass. It's not glass, it's like acrylic, but it's more painful. And I find that patients, before the silicone options came out, and if Summer shows you, it's actually not that
bendable, this one,
but it's softer.
But it's soft.
So it's a little bit, my patients prefer this one, and they prefer the vibrating, because then many times they can do their physical therapy at home without needing to go to someone, because they feel like I can actually get to spots that my physical therapist with her finger could get to, but now I can't. Now I couldn't by myself, but with this wand, I can get there, and then I can work on these spots. Now, we're going to get into physical therapy, and I want to just put out a very quick disclaimer. If you are not comfortable with your body, please do not use a wand on vibrating right away. You have to explore. I would put your finger in and see how you feel. Do a telehealth visit, YouTube some videos about pelvic physical therapy, but do not just go directly to these tools without reading up, watching something, or doing a consultation with anyone, including us, anybody. I just don't want anyone to hurt themselves, because if you're too aggressive, you can hurt yourself. So that's just my disclaimer out there. These tools are available, but you have to use them responsibly. Next slide. This is a sexual buffer. So for patients who want to have a child, who are in a rush, who they're on a clock, and they don't necessarily want to work on their muscles. You can actually work on your muscles and still use this buffer at the same time. But this buffer is not going to treat any problems. What this buffer is, it acts as a buffer. So if you put this on, if your husband or your partner puts this on the base of his penis, they come apart. There's actually 1, 2, 3, 4 in a box. And depending on the length of the penis, you can actually put this at the base of the penis. And when he enters, it acts as a buffer. So he can't hit the muscles. And so for someone who wants to have intimacy, but wants to have a child and wants to get your partner to ejaculate, but can't fathom the pain of thrusting, I often tell patients that this is a tool you can use to help you relieve pain, but it is not going to solve problems. And so a very big disclaimer out there, it is not going to solve your problems, but it will help. And you can use 1, you can use 2, you can use 4. It really depends on obviously if you're trying to have the less you use, the more your husband or partner will be able to get it. And so you can customize this. And this is actually called the O-Nut. And you can find this as well. And I'll just type that in, O-Nut. If you type in O-Nut on Google, but it has to be like, somewhere you'll find the link. Next slide.
Sorry, just a time check for you both. It's 6:20 p.m. So we're gonna have to maybe try and wrap up a few minutes, like by 6:25 or so, if that's all right.
Absolutely. A lot of this stuff is redundant. So this is going to be a quick section talking about, so Dr. Ahmed said that her first line of defense is physical therapy. I always tell people physical therapy is no medicine, it's no surgery. It's pretty much using a lot of education in how to start getting these muscles to function the way they're supposed to function, strengthening them by doing Kegels. You've all heard of Kegels. Kegels are not for everybody, but that's learning how to do them properly, or pelvic floor muscle contraction exercises to help with weak muscles, or learning how to release the tension and down train and make these muscles less spastic to help with pain syndromes. So really the goal of a physical therapist is, one, to diagnose what your muscles are doing wrong. Are they in this constant spasm, or are they really, really weak, with a vaginal exam? So every pelvic therapist will perform a vaginal exam to tell you if your muscles are doing what they're supposed to be doing. She'll ask you to squeeze, you'll squeeze the muscles, she'll ask you to release, and she'll kind of diagnose based on how strong you are, how great your endurance is, or if you're squeezing all the time and shouldn't be. And during this session, of course, the therapist will also be able to diagnose if you're experiencing vestibulitis or vulvodynia, meaning pain in the outside of the vaginal canal. In that first picture that we showed you, where it showed the vulva and the vestibule, where the smaller labia and the larger labia are, is your pain there, or is it more internal? So this is where the pelvic therapist helps diagnose what is causing pain and where the pain is coming from. And then we'll put you on a very special set of exercises to help deal with that pain. Again, dilators are not for everybody. Kegels are not for everybody. So it's really a matter of the therapist diagnosing what your problem is and how to start solving that problem. Next slide, please. And again, this is very redundant. Dr. Med kind of covered all of this. These are different symptoms that a physical therapist can help with: is urinary problems, urgency, frequency, painful urination, inability to start the stream of urination, stopping and starting urination, incomplete emptying of the bladder, constipation, straining, pain during a bowel movement, pain or pressure in the vagina or rectum, pain with intercourse, a bulge in the vagina or rectum. These are all abnormal experiences. Even if someone says, oh, I have that too, it doesn't make it normal. It's common, but not normal. Next slide, please. I think this is also redundant. We talked about, the things that women can experience after giving birth. I think the most under talked about one is probably scar pain. A lot of women experience an episiotomy or a tear during delivery, and then 6 weeks postpartum, they're expected to have sex again. And all she can think about is, don't come anywhere near me. And so there's obviously treatment for that as well. You should not endure pain with intercourse after having a baby. If there's scar pain there, that should be addressed. It can be massaged just like any other scar. When a scar starts to heal, it kind of grabs the tissue around it, healthy tissue around it, creating scar tissue, making that area even more tense. And so not allowing the muscle to expand to its normal length. And so a pelvic physical therapist can help teach you how to massage that scar, help that scar heal, even with pelvic floor contractions and releases, helping regain that normal length of those muscles to do what they're meant to do. A pelvic therapist will also help talk about your core strength, regaining your core strength the safe way before going back to doing sit-ups and hitting the gym and CrossFit and all that stuff. And so pelvic physical therapists specialize in these specific treatments, treating incontinence and sexual dysfunction and scar pain and adhesions and visceral restrictions in a very non-invasive way. Next slide, please. Just really to add a study in there, a lot of everything that we do is evidence-based. So this is evidence-based work. It comes from people who've done case studies and studies who have pretty much shown that this is very effective treatment. 50% of mothers experience urinary incontinence during and immediately after pregnancy. Many studies report that pelvic floor exercises are an effective way of strengthening pelvic floor muscles and reducing urinary incontinence. They also say that it helps reduce pelvic prolapse by a few degrees, and in some cases prevent you from having to have surgery. And generally speaking, any new mother should really, if she has access to it, see a pelvic floor physical therapist, even just for an assessment, to make sure that there is no weakness or damage in the pelvic floor muscles. Next slide, please. When should I seek help? I think at this point, you're all pretty clear what is not normal. Seek help when something doesn't feel right. I mean, in a nutshell, that's the best advice I can give you. If it doesn't feel right, seek help. Speak to your gynecologist, speak to your midwife, your OBGYN, speak to your GI doctor. Things are not the same as they used to be, or I'm experiencing pain out of the ordinary. So many people can experience the same exact issues, but not have the symptoms that you have. So don't, especially now we're going to bring this back to Muslim women. it's taboo to talk about the vagina. It's taboo to talk about the pelvic floor. You know, you're expected to go back to having sex and please your husband. It is not taboo to discuss pain. It is not taboo to discuss something that is not the same as, you know, you would expect it to be, or prior to pregnancy, or post-menopause, or even when you first get married. I've treated women who haven't been able to consummate their marriage 2 years in, 5 years in, 6 years in, haven't been able to have sex, and the in-laws are asking for the babies. And so at this point, they are feeling ashamed, they're feeling ostracized, they're feeling like, who do I speak to about this? I can't even have sex, let alone get pregnant. So you should seek help when you feel that something is just not right. Next slide, please. Treatment involves a pelvic floor exam, a core exam, possibly a pelvic alignment exam. Sometimes the pelvis is doing funky things. Sometimes it's just either from a fall or from pregnancy or delivery, the pelvis can rotate backwards or forward or in or out. And so just like any other, you know, bone in the body, it can dislocate sometimes, or pubic symphysis pain in the front here or in the groin can also occur either during pregnancy, postpartum, from an athletic injury, from riding a bike, horseback riding, a fall. Any of those can create pain in the pelvis. And so treatment involves finding, you know, that you have good alignment in your pelvis, making sure you have good pelvic floor muscle contraction, release, and training you to strengthen your core and pelvic floor muscles the safe way. Treatments are usually 45 to 60 minutes long, depending on where you go. Again, teaching you how to relax the pelvic floor muscles as well as contract them. It's called up training versus down training. Biofeedback is a device that's used with vaginal or external sensors to help you visualize what these muscles are doing. Sometimes a lot of women lose sensation in the pelvic floor and they can't feel if they're contracting or releasing, or they're not sure what muscles they're supposed to be contracting or releasing. And so biofeedback is a great way to be able to see what your pelvic floor muscles are doing on a screen. So I joke and I call it a video game for your butt. So I have women contract their pelvic floor muscles while they see something on the screen go up, and then release the pelvic floor muscles while they see the same, you know, device drop, to get a visual idea, and it makes that neural connection of what the pelvic floor muscles are doing and if they're doing the right thing, contracting when they're supposed to, releasing when they're supposed to, and if they're not, that's where pelvic floor dysfunction occurs. Typical treatment is 4 to 8 weeks, 2 times per week. Usually my postpartum moms, I have them come maybe once a week just because I take into consideration they have babies. I am also very aware, Dr. Ahmed and I are both moms, and we're very aware that therapy requires time outside of your home. And so obviously we work with our ladies to make it the best for them. Next slide, please.
So very quickly, there are different other treatments aside from pelvic physical therapy, which is obviously number one, but there's acupuncture, so if you can find someone who will work on your pelvis, craniosacral treatments, which is an osteopathic manipulative technique that's done that connects your cranium, which is your skull, all the way down to your sacrum. And so your body is a unit, it's all connected, and working on this can affect your sacrum, which is the lower part in your pelvis. Yoga, it's wonderful, it's great. You want to do things that don't hurt you, that help you. It's not about working through pain. And restorative yoga is even better for patients who have a lot of difficulty with that flexibility, using blocks and aids to help you do those exercises. So when you're watching a YouTube video on yoga, if you can't do it, don't force yourself to do something. Try to amend it so that you can do these techniques. It's all about getting blood to your pelvic floor. So just sitting all day or walking and being at work, you're not getting that motion. And during Salah, when we pray, we actually go down and we come back up. And then a lot of these positions are similar to when we're doing yoga or different positions. And so that helps when you're doing that 5 times a day. But I always say 10 minutes of yoga every day are super helpful. And you can work your way up. So many patients enjoy it and they go up. Meditation, a lot of people find doing something that reminds your brain that doesn't feel like it's in pain. So whether that's coloring, whether it's praying, whether it's singing, whether it's anything, knitting, or I find, just sitting and doing the typical meditation hard to do, and taking that all those thoughts in your mind out. But if you, I think it's just as good to do something that distracts you at least 1 to 2 times a week, where you feel, when I did that, I didn't really notice my pain. And that really can help retrain your brain, that connection. And then if patients need therapy, sex therapy, cognitive behavioral therapy, and OCD therapy clinics are available. And because of that, there are so many conditions that actually need to be addressed, and you can't skip these. If you have a sexual trauma, you have to address it. If you have something that's, you know, an OCD tendency, like pulling out hair in your vaginal area, these OCD tendencies, not just being like a clean freak or being like, that's not OCD necessarily. It's not being a type A person, but we didn't talk about that. There are a lot of people who are very anxious and very stressed out, and they are typically the people who are clenching their pelvic floors. And those can be, you can have no condition that's causing you all of a sudden now to have jaw pain. You're clenching your jaw and you're having trouble waking up in the morning with pain in your jaw. You might be having headaches and migraines, and you may be clenching that pelvic floor. So when you're stressed out, your response is to squeeze, and you don't realize you're doing it until someone's told you. And now you think about it, and all of a sudden you're like, I am squeezing my butt all day long. And that's something that you can work through. And obviously working through that stress and anxiety that's making you work, stress and clench, is also very important. If you don't address that, and mental health is just a huge topic that's so stigmatized and not discussed, and a whole other lecture could be discussed on that. Next slide, please. Second line treatments. This is where I get into with more of my patients with consults. Once they've done a follow-up, they've gone after my initial consult, I give them recommendations on different medications that might help with their pain. And depending on where they are in their journey, if they're very early in their journey and they don't want to start a nerve medication, I'm never going to force anyone to start something. If they want to try conservative treatments, I'm all for that. If they're having some vaginal burning and it's intense and painful, I might try creams. If it's something urinary, I might try some medications like a similar Claritin antihistamine to help with some of that. If they're waking up at night, that can also help with that. There are also trigger point nerve block injections that I can do, and this is way more aggressive, but not so aggressive that we're having surgery. And for some people, doing injections or trigger point needling is actually less aggressive compared to taking an oral medication by mouth daily. It really just depends on the person and how they've grown up and what their connection or their feeling sure in medication are. So next slide. Typically, our injections, what I do is used to decrease the tension in the pelvic floor, improve the blood flow, decrease the sensation and impulses that are around those nerves, and then decrease the inflammation. Next slide. These are the nerves. It's just a schematic, the piriformis muscle. Samir, if you click on that one, you just hover over it. That's that muscle I was talking about. There's a huge little sciatic nerve. And when people feel pain going down their leg, they think, oh, I'm having something coming from my back. And many times it's that sciatic nerve that's being compressed because their piriformis muscle is touching it and it's bothering it. And all of these other little nerves, the pudendal nerve and the posterior femoral cutaneous nerve we talked about, these are the nerves that go directly into the pelvic floor. Next slide. I use ultrasound guidance to do my injections, so I'm always aware of where I'm going, and I want to make sure that I know exactly where I'm going. And so if someone is doing it without ultrasound guidance, I would, possibly consider holding off on that just to make sure. As a GYN, they're trained to do it intravaginally. I, as a physiatrist, am trained to do it outside. So I don't do any internal inside the vagina. I go externally into the pelvic floor through the butt cheek. So I'm not going inside. So it seems very scary, but we're not going in the vagina. It's way less painless when I do it out externally. And I'm also doing it under guidance, whereas internally you cannot. You're kind of going into shooting an arrow into a hole and hoping that you get it. But GYNs often know where after experience, they know where they're going, but the guidance helps quite a bit. Next page. Ilioinguinal, same thing. There's always a nerve block that's available to do for any of the nerve pain distributions we talked about. So this is just a nerve of that first nerve that we showed in the groin area. Next slide. And this is how I would do it. There's an ultrasound machine there that use a probe. And then where it says, where there's like a little black dot, that's where I would go in and do the injection and go through. And as the nerve travels through, when the patient stands up, they might feel a surge of liquid going down and they feel, oh, my nerve feels better. I feel numb now. And that's just one particular block. But when we do them in different, and obviously each block is very different, but this is just one that was available online that I could show. Otherwise, other blocks would show genitals, and I don't think that's allowed on you Google. Next slide.
Awesome. So thank you all. I know we went a little bit over time and we wanted to be as comprehensive as possible. This will be available on YouTube as of tomorrow, inshallah. So I'll be taking the recording, I'll be adding captions to it so that it's accessible. So if you're listening at work or home, you don't have to play the volume. And then we'll hopefully be translating it as well. So this will be something that will inshallah be in different languages too. So we didn't get too many questions and we're over time. So I want to respect, Dr. Samori and Dr. Ahmed's time, but if you have questions and you haven't sent them, we do have contact information. So Dr. Ahmed is reachable. You can take a screenshot of this slide and then definitely reach out to her. She's an incredible wealth of information, very responsive, mashallah. So definitely reach out. And Dr. Samori, the same, based in Tampa, Florida. So if you're in the area there, you could actually see her in person and also reach out by email. They're both really well connected to other professionals. So know that if you're not here, then inshallah we'll be able to find you support wherever you live. Do you both have anything else to add to that?
We didn't mention C-section scars, and I just really quickly wanted to mention that if you have a C-section, you can still have pelvic floor dysfunction because you're still growing a baby inside of your uterus and stretching out your pelvic floor muscles, and you're also still getting a scar. So that is technically a location for pain as well. So don't feel like just because you had a C-section, this didn't apply to you. This could definitely apply to you as well.
Thank you. I absolutely agree. And just to piggyback on that idea, when they're cutting through the muscles here, it is affecting everything beneath it, the bladder, the uterus, how your core heals. Don't forget that you want your core to heal properly as well postpartum. And so there will be techniques taught to massage that C-section scar and help bring things back to normal length. So thank you for bringing that up, Dr. Ahmed.
Awesome. And then, yeah, my info is available as well. I'm on Instagram. And so I think what I'll do now is I'll just stop screen sharing. So you'll have our 3 slides of contact information on the side. So feel free to reach out to us. And yeah, how do you